I'll go ahead and get started if it's okay with everyone.
Yes, good morning, everyone.
Good morning,
Good morning.
Gerald. Lovely to have you. Okay, perfect. So good morning, everyone. Thank you for spending your Sunday morning, excuse me, with us.
Not
It's
Monday yet.
delightful. Not Sunday yet. We have to earn our Sunday, guys. So
No, not Monday yet.
Of course, yes, not one day yet. So lovely to have you guys over here. Um, Thank you for joining us today. So we are here in an initiative that we call the Sewa Forum. So Sewa Forum is a 2-day gathering that brings leaders and practitioners from across various fields like nonprofit, education, healthcare, philanthropy, tech, and community sectors. The whole idea is that we really wanted to create a space to connect and share experiences and learn from each other. And the reason for doing it is so that we can create a greater impact through the service that Seva is engaged in, and through making this an accessible way for community members to learn how best to serve wherever they are. My name is Kavita Tiwari, and I'm the Executive Director of the Seva Houston chapter. I'm very pleased to welcome you today. My job today is to learn from you and for all of us to get together and have a wonderful discussion. In yesterday's session, which is part of the day one of Seva Forum, we had talked about volunteerism, youth empowerment. And in case you missed that session yesterday, please feel free to go to our YouTube live and check them out. Our theme today is healing beyond the clinic, medical volunteerism, healthcare access, and community-based care in America. In the United States, the access to healthcare is still being impacted by provider shortages, insurance gaps, locations, and barriers, especially for our underserved communities that we are so close to. At the same time, community organizations, free clinics, healthcare professionals are finding new ways to bridge those gaps and to bring care closer to those who need it. Today, we'll explore what makes these models work, how medical volunteers can support mentorship, partnerships, training, and community based care and make healthcare more accessible to everyone. Today, we are joined here by leaders with experience in public health, rural healthcare, free clinics, specialists in fields, and I'm looking forward to hearing their perspectives on how to best serve people we are closely working with. But before we do that, let's learn a little bit more about the organizations that's us, Seva International USA. To do that, I would love to invite someone who has been closely involved with building Seva's works, strengthening our community engagement over the years. And it is my honor to invite Prem P of Programs and Projects at Seva International USA to deliver opening remarks. With more than 25 years of leadership experience in healthcare and technology industry, he has served in various roles such as a CTO, a CIO, and a CISO. He now leads Seva's national programs across healthcare, education, disaster relief, youth empowerment and leadership, and community development. So please join me in welcoming Mr. Prem Pasaluri to share with us his insights about his journey at Seva and Seva International USA.
Thank you, Kavitaji. Namaste and good morning to the distinguished panelists and other guests. I know Kavitaji is going to introduce all the panelists one by one, so I don't need to lose time reading all your names right now. I was invited to just talk about a bit of Seva work, what we do. Just so you know that Seva International USA, we are a volunteer-driven, non-profit humanitarian organization rooted on the timeless ethos of Sewa. That means selfless service. So we were founded in 2003 in USA. That has been now 23 years. So we work. We are present in many countries across the world. We work in 40 countries, and within USA we have 46 chapters in all major cities and states. So my responsibilities within USA, I do look into some projects, programs outside USA too. So, but within USA, we do, our focus areas are disaster relief. Then we work on the healthcare, which we call as health and wellness. Then education, then family services, then food security, and many other like youth empowerment. So all these programs we have within Sewa USA. So disaster relief, whether that is you say Ukraine war or Turkey earthquake or Texas floods last year, whenever there happens, say whether man-made or natural disasters, but you can see Seva foot soldiers there itself. If Seva chapters are around, if Seva chapters are not around, then still our work can be found there. So disaster relief goes in 4 stages for us. Of all the within USA, actually the disaster-prone areas, like which happen to get into that frequently. So we work with the communities on the disaster preparedness. Then if disaster happens, then the rescue, relief, and rehabilitation, we work on all these 4 stages of a disaster. Actually, as a matter of fact, here today, Madan Lutraji is also here with us. He is our veteran volunteer who got Texas state government's award also. He is always there whenever there happens a disaster on foot, that a foot soldier. So that is our disaster work. And again, with there too, as you know, disaster in people mind that stays for a couple of weeks, couple of months. For Seva, that goes for years. Means hurricane after, because some of you are from Houston, we were working on that in rehabilitation project even after 5 years of Hurricane Harvey, taking an example. Similarly, we work in education sector with so many projects called Aspire projects across the country. Then we have something called family services, where at the family level, if a family is struck, with some disaster at the family level, it can be a domestic violence, it can be a death in the family, it could be culturally sensitive aspects too. So we try to help those families until they stand up again and can fly on their own. Food security also another problem, many communities face within USA. So we try to help there to support them and working with the government organizations and other organizations. And doing all these things you can find on our website. Even our tagline says we work better together. So always we work with partners that includes FEMA, that includes AmeriCorps, that include Homeland Security, that's government side, Rubicon, then so many other organizations, non-profit organizations, corporations. So we work with any organization where the mission is common mission. Coming to this health and wellness, which is one of the important tracks for Seva within USA. We do have multiple like sub tracks there within that, because when we say healthcare, usually we think of all these hospital systems, treating a patient, but all that is aftermath. But very importantly, usually many times we miss that preventive, like we don't need to give and take healthcare, right? If we maintain good health. So Seva focus in that area too, besides, the treatment, all that. We call it, we do that through different ways. We have something called Stop Diabetes Movement. We have something called Self, that is through our workshops and practices, daily practices, The self-program is that sleep, then exercise, living in presence, and food. Through these 4 good habits, we can improve the health. We don't need to get into health issues. So we do that through across our chapters, and we conduct yoga sessions. So all these things through awareness as well as the practices we bring. So that's more of preventive, and also we do conduct many workshops, mental health workshops, and all those. Besides that, we do conduct, we do run free clinics across the country, and we are working to build more free clinics in partnership with, actually today only, we got an opportunity to, we'll be working later, for our Alexandria Center, which we are bringing up, another one. That is free clinics. Then we also do work on the work with the aspiring medical professionals, so that to bring this selfless service, that is Sewa mindset in them, because that's your profession. But when you add to your profession the empathy and selfless service aspect to that, then the impact grows multifold. So that is what we try to do by working with these young professionals. Then we do, say many Sewa camps, and also like we do travel to other countries, where there are no medical facilities much. So our physicians go and do help there in the medical camps and come back. And in our network across the country, we have around 250 plus physicians in our network, but that's our own. But besides that, we do work with many physician professional organizations in partnership with them, including RP is one of them, one of our partners. So this is how we work in the on the healthcare side. So we work on both preventive as well as the healthcare, the regular healthcare. So this is our work, how we do. With that, Kavitaji, I give it back to you. But I'm ready to take, actually, I'm looking forward for this 2 hours of discussion. Again, thank you very much, especially for who are on the West Coast. And usually Sunday is meant for family, but all of you came forward to spend these 2 hours with us, which is more for, thinking of society. Thank you very much for that. And I'm ready to take notes to all the inputs what you're going to give in this next 1 hour 50 minutes of this conversation, so that we can plan actionable items out of that. With that, Kavitaji, back to you.
Thank you so much, Premji. So with that, I would now like to introduce our distinguished panel today. Our first panelist today is Dr. Maggie Sauer. Dr. Sauer, very warm welcome. She is the director of the North Carolina Office of Rural Health. She brings more than 30 years of experience across direct patient care, community engagement, nonprofit work, and has led the Office of Rural Health for the past 9 years. Welcome, Dr. Sauer. Our next panelist is Dr. Joanne B. Ritter. She is the medical director of the Arlington Free Clinic and assistant service chief in internal medicine. She has served as a medical director of the clinic since 2010 and has been a volunteer medical provider there since 2000. I think this is such an amazing opportunity to learn from her, especially given that we are opening a partnership for Sewa in Alexandria. So thank you so much, Dr. Ritter, for being part of this initiative.
Can someone update the slide? Yeah. Okay.
Thank you. Next up we would like to welcome Gerald Johnson, Executive VP. Gerald has been Executive VP of the Bernard J. Tyson Office of Health and Chief Culture Officer at the American Heart Association. He brings extensive leadership and experience across marketing, partnerships, fundraising, and community engagement, along with a long record of volunteer leadership across health and social services organizations, one of them being the Big Brother and Big Sister, one of my favorites. So thank you for being here, Gerald. Next up, I would like to welcome Dr. Ellen Beck. She's the co-founder and advisor at the UC San Diego student-run free clinic project. As the founding director of the clinic, she has worked to provide high-quality care to underserved communities while advancing humanistic medical education and preparing future healthcare professionals for community service. Thank you so much, Dr. Beck. Next up, I would like to invite Dr. Pranav Loalka. He's a fellow historian, is a board-certified cardiologist with Houston Heart in Houston, Texas. Dr. Loalka began his medical studies at the University of Missouri in Columbia, Missouri. He went on to complete his internal medicine and pediatrics residency at Tulane University School of Medicine in New Orleans. He then finished his fellowship in cardiology and interventional cardiology at the Baylor College of Medicine, Houston, Texas. He also currently serves as the president of Sewa International Houston chapter and engaged in community health initiatives in Houston. Thank you so much, Dr. Loalka. Next up, we have Pranjali Dani. Pranjali is the associate director of the Doctors for Sewa initiative at Sewa International. She leads initiatives that mobilize healthcare professionals, medical students, and volunteers to expand on healthcare access while also advancing physician engagement, mentorship through initiatives such as the Doctors for Sewa and the Evolve Mentorship Program. Thank you all for being here today and a very warm welcome. So today's discussion is going to be 3 rounds of questions. I will be asking questions to a specific panelist, but please feel free and an extension of invitation to all the other panelists to add to whatever your fellow panelists are sharing. We would like to make this organic and very engaging for all of you as well as for the audience that is joined today. With that, I would like to share my first question with you, Maggie. Maggie, you've spent much of your career working with rural communities, including in North Carolina. What are some of the healthcare challenges in rural communities that often go unseen when we look at the healthcare systems from a national perspective? So what are your thoughts on that?
Thank you. And thanks so much for having me part. I mean, this group is just an amazing group of professionals, and I'm really honored to be here. So thank you so much. Yeah, a little bit, I think, about the perspective that I have and why I believe that it resonates with this group and with this organization. Our office is a federally designated Office of Rural Health, the first in the nation. It's 54 years old. The thing that's important about that is because our founder, Jim Bernstein, was a Peace Corps guy. And he was in the Peace Corps. He came back to the United States and said, there are rural areas in our country that look like where I've been placed to do my volunteer work there. And he then became impassioned by that and started the first Office of Rural Health in the nation. And the most important part of what he did is always say you walk with the community, not in front. You walk beside them as support. And so I think the big thing that we see a lot with rural health are a number of the things actually that Jim saw when he created the office. And that is, I think the unseen things right now are environmental conditions in our rural communities. There are a lot of places where industry thinks they can put things in rural so it's not seen. And it has a lot of health implications for our rural residents and eventually our urban family members as well. So I think that's part of it. I think the other thing is when you think about international work and really trying to ground ourselves in people's culture, how they feel, how they look at the world and those kinds of things, that is key component to providing rural health care as well. You have to think about the culture of that community. You have to think about, Is there food available? Is there water available? Transportation? All those things that you brought up earlier as sort of these beginning points are really the beginning points of health. And unless you have transportation and food and all those things, how can you really have the opportunity to be as healthy as possible? So that when they show up at the cardiologist, they have the opportunity to have fresh water, food, access. And we have so many maternal deserts across the country right now, food deserts across the country. All those things are such important pieces to our health. And so I would say, you've got to look at those pieces. You've got to look at transportation. You've got to look at environmental justice issues. And finally, broadband. That's the other thing. Our world is increasingly digital. And you think about broadband now as just as much as an access to electricity, because so much of it is digital now. And that health access can be increased if we have some access as well, virtually. So those are kind of the cornerstones that I consider and that I think we don't always think about when we're thinking about connecting people across the world, connecting people across our communities, whether it's urban or rural.
Wow, Maggie. This is when you talked about the Peace Corps piece, I still remember the first time I went to volunteer in one of the rural communities in Houston post Hurricane Harvey. So I live in Houston, pretty much a suburb, in a very well planned out suburb. You don't know what exists out till you go and visit, and it's exactly my emotion. And every single volunteer that went from Houston, associated with Houston chapter, when we went there, we were like, this does not look like America. Because our reality is very different than what exists in rural America. And it was such a shock to the system, especially because it was right after a major hurricane, one of the biggest hurricanes America has seen. And the disparity was huge. People are really struggling, and it's all about equity, not just one piece, but every single thing. The digital piece is, now that you're talking about it, a lot of us access our medical information, doctors' portals and whatnot, right? So, yeah, this is quite a start, I must say. Pretty loaded realization.
And I would say Hurricane Helene in Western North Carolina was absolutely devastating. So again, most people hear about Asheville, North Carolina. Well, there are 17 counties across the western part of the state that were absolutely decimated. So I think learning from all of you and from the work that's been done previously is priority.
Thank you so much, Maggie. Absolutely. Okay, next up, I have a question for you, Dr. Ritter. Dr. Ritter, you have spent many years caring for the uninsured and underserved patients in the Arlington Free Clinic. From the clinical side, what are some of the barriers you see patients facing even before they make it to you, even before they reach a doctor? So what are the barriers that you see often in your experience?
I did write down a few notes, so I'm going to refer to them a little bit. But first of all, thanks for having me. And I liked Maggie's introduction there. To put it in perspective, Arlington, I think, was voted the healthiest city, although it is a 26-mile square county, the healthiest city in the United States for about 7 years in a row. But if you go from there to southwestern Virginia, to Grundy, or one of those areas, which is right near North Carolina, it is a completely different world. I think there's still some common areas, but I like the fact that you said you have to know your community too, because if you don't, then you don't know what they need. So in terms of the barriers for our patients, we have 2/3 of our patients are Latino.
Mm.
And I think that one of the biggest is just language and the ability to speak the language and understand how things work in the United States. If I were to be put down in a foreign country in Germany and told I had breast cancer, and you don't have any resources and go out there and figure out what to do, right? Save your life
Yeah.
and not leave your children motherless or parentless. So that's one of the biggest things, I think. Second is a fear of interacting with any safety net providers for fear that they're going to be detected if they're undocumented. So I think a lot of our patients limit that interaction quite a bit. And by the time they're in extremis, kind of by the time they get to the emergency room sometimes. I think as a clinic, there's a lot you can do to make patients feel like they're protected if they come into the clinic and trust you. And I think that's a big part of having patients seek care, and at the hospital as well, right? Because we know about agents going into emergency rooms or whatever and looking for patients. In addition to the literacy issues, there's also health literacy, which is probably common among a lot of our patient populations. Some of our patients that have never seen a doctor in their fourth or fifth decades, they've never seen a dentist. They only know that when you get sick, that's when you go to be cared for. Some of them rely on over-the-counter medications they get from their home country. We had a patient who got a medication at a local, it was like a local Latino store, and the medicine is known to have very high levels of dexamethasone in it and non-steroidal anti-inflammatory meds. Yes, she was Cushingoid when she came to us, but she did. So that kind of stuff they rely on unproven or even dangerous treatments. And then in the end, most of our patients are working more than one job, and they just don't have time to access care. And it's the same no matter where you go. The food that they have access to, the cheap food, is pretty horrible. They can get a lot of food, a lot of calories at McDonald's, but it's not good food. So I think they just feel that's the last thing they have. It's that pyramid of what's urgent, and if their health is kind of towards the bottom of that pyramid. So I think that's most of the things that I came up with.
Yeah, and John, this is not just in healthcare; it's in everything. When you're trying to reach them for after-school programming for kiddos, right? What is important? Mom and dad are not at home; they have 3 jobs.
Right.
So, who's going to get the kid to the after-school program? You have X number of dollars. Either you pay rent, or you do your utilities, or you eat healthy food. What are your choices? Being homeless, or eating healthy, or not getting electricity cut off, or eating healthy. So it's like a whole complex issue, and everything is interconnected. So
Right. Yeah.
So what you're saying though, do you have any strategies in place to? I'm seeing the immigration situation also impact the programs that we do. How are you tackling that piece? Are you actually employing some literature? How do you do the outreach to make them more comfortable? What's your strategy there?
Well, we did start handing out little cards the size of just like a little business card, and it has on there what they should say if they're approached. We actually just redesigned our waiting room, believe it or not, because it was
interesting.
It was an open room where people could see inside. So now our patients are brought back, and there's 2 doors and a foyer, and you have to be allowed in. And then I think never ask them about their whether they're documented. And so I think that's important as well. And I think there's a reputation of the free clinic that the patients feel safe with it. And that's going to be important with any, with any clinic. We also, the other day, there was some chatter about ICE agents boarding buses. So we offered all of our free clinics, our free clinic patients, video appointments. And, one of the benefits of the pandemic is that everybody kind of knows how to do that now. The infrastructure is there. So a lot, and then we ask patients too, are you afraid to leave the house? If so, we can call you and try to meet them where they are.
Yeah, meeting them where they are, very, very important. Not just the physical meeting, but also addressing their emotional situation and the fear equation that has popped into everything.
Sure, and that's, I guess, behavioral health. We have a pretty good behavioral health program. A lot of our patients are, their spouse was deported or detained, or they're living in fear of it. And that definitely impacts their overall health care. So we try to make use of those behavioral health resources.
Thank you so much, Joanne. That was very insightful. Thank you so much. Gerald, my next question is for you. You have been involved in some amazing organizations like the American Heart Association, the American Diabetes Association, and Meals on Wheels. From that experience, what have you learned about the role of community-based organizations and how they can help in improving people's health beyond what happens in hospitals and clinics?
Yes, good morning, good afternoon, everyone. The American Heart Association is delighted to be here. And thank you all for the great work that you do, because I think together we're able to do things that none of our organizations alone would be able to do. So delighted to be here. And to my esteemed panelists, I'm learning from you, and hopefully I can share something that'll make your work even more enriching as well. But to your question, I'll start by saying I really do believe that local organizations are really the vital, they're the essential, they're actually the window into what is actually happening in local communities. And so what do I mean by that? I mean, they're the glue. They're where people go. You were hearing immigration services, you were hearing other things. They are trusted. They are a safe place. They know individuals on a first name basis, and they know their families. And so when I think about the role that local and community-based organizations play, I think that that's where you start. You've heard Joanne and you've heard Maggie say, this notion of meeting people where they are. You can't begin to do that unless you know where are they, who do they trust, and more importantly, where do they go to get their information? And so when I think about your question, those are some of the things that I would say. And then I would also say that they actually will help other organizations understand who the influencers are in the organization. So it could be church, it could be a teacher, it could be a coach, it could be whomever it is. It could be Big Mama that makes the best ... at the restaurant that everyone goes to.
Yes.
So they will help you understand who the influencers are. And then they will also help you understand what's worked and what's not working because of all the people that have come before you. So I think that the local organization serves many purposes, very essential, yes, vital for the services, but they also are a place that serves as a bridge. And so you may, what do I say about that? So they may not themselves directly have the answer or be the service that you need, but they can say, look, I can't do that, but I want you to go talk to Maggie. I want you to go talk to Joan. I want you to go talk to someone else that can take you where you need to go, because I can't do it. So I see them as the essential thing. And I'll share a quick story, because this past weekend I was with the National Association of Community Health Centers at their national conference in Las Vegas. And for those who are familiar, they reach 53 million people in the United States, 1 in 7 from a health perspective. And the beautiful thing about, again, local and community, there was a story about a student, because in addition to health, they also provide educational services, et cetera. And this one young boy, his name was Johnny, he was coming to school, and they were recognizing that he was having breathing problems. And so obviously, because it's a health center, they made sure that they got him some asthma related things, helped him with his breathing. All those things were great. But because of that local organization, because of the trusted nature, because of the family, someone, one of the healthcare providers said, listen, we probably need to go and see where he lives. And when they went to his home, they realized that the home had a lot of mold
Molds.
and
Yep.
asbestos issues that were actually causing his asthma and his breathing. And so I say that to say if you don't have local, trusted, woven pieces that talk together, Johnny would have gotten the asthma medicine that he needed, but no one would have checked his home. And so they wouldn't have fixed the root cause of things. They just would have addressed the symptom. So your question to me is what have I learned? I learned that they're essential. I learned that they're vital. I learned that without them, bigger organizations don't stand a chance at meeting people where they are or being effective at the local level.
Well, Gerald, this is so true. And a little anecdote I would like to share is during COVID, we run an after-school program in a school district embedded in the classroom. And one of our AmeriCorps members, which is just like Peace Corps, but you're serving in America, she was working with a student, and he was bilingual, and he was really struggling trying to, voice out the words and pronounce them in a correct way or speak legibly. And everybody was wearing masks at that point, right? And she was trying really hard. And one day, she was getting frustrated that how come this? He's a smart kid. Why is he not improving? And guess what? One day he took off his mask and he had a split lip. I don't know what that condition is called, but yes, he had that. And no matter how hard he tried, he was not able to do what he was expected to do in the classroom. And at that point, Sewa got involved, and some of the physicians got involved on our end, and we were able to find him a donor who could sponsor his, I think that the surgery that he needed. So, the advocacy piece is what I think the organizations who are meeting these people in the communities that they live in is a huge part of how we get them across that hill, just that not giving up, just following through and see what's going on and going behind the root cause, like in your story, right, Gerald? So yeah, that's exactly our experience. I'm so grateful you're echoing that as well. Thank you for sharing that story with us. My next question is to Dr. Beck. Dr. Beck, you worked at the intersection of medical education and community service while you are running a wonderful free clinic as well. How do we move from volunteerism being a one-time experience, right? You one and done. I went there, I did this, and I did my good deed and I can walk away feeling good about myself. How do you take that one thing and transition into an experience when that medical student thinks like, this is my calling? Yes, medicine is an amazing field. You do good for yourself, your family, but what is the larger purpose behind it? And a community well-being throughout their professional careers is what their final outlook is. So, Dr. Beck, it's all yours.
Can I just check? Can you hear my voice well? You were
Yes, you are
concerned about
great. I can hear you clear.
All right.
Yes.
And thank you also, everyone. And I just want to follow on my two colleagues who spoke about community members as trust bridges. I think we really need people who work with us, who are from these communities. And in our free clinics, we have had key individuals who are promotores, who are staff, who are initially patients and volunteers, and then staff, who are the trust bridge to the community. And I just wanted to reinforce that before I began my answer. So our students, they arrive, I believe that most medical students, most health professional students, they arrive with passion, compassion, and a desire to make a difference. And our systems tend to beat it out of them. Let's just face it, academic medicine, medical education, we have this belief system, you lift yourself off the floor and you're supposed to learn, and we beat it out of them. And programs like student run free clinic projects keep it alive. And they don't only occur, it's very important that these trainings and these teachings don't only happen in the first and second year of medical school. Like, oh, students say to me, I'm nice to my grandmother, what are you teaching me? And but remain throughout the third year, the fourth year, into residency, and then pathways into practice and into faculty roles, so that young and future physicians and health professionals have the tools and skills and reinforcement and mentors and patients who teach them, so that those dreams stay alive. So at our free clinics, which have existed in San Diego now, student-run free clinics, for about 30 years, and then we've helped places all over the country. I had the honor of starting a national training called Addressing the Needs of the Underserved, where we had more than 300 faculty and physicians and dentists from around the nation, and then they returned to their schools and worked to help transform philosophies and approaches. So our philosophy, we have a core philosophy at our school, at our free clinics. One is empowerment, create environments where people take charge of their life and achieve joy and well-being. Two, and our job is environmental design. It's not just fixing, and it's long term, it's continuity. And what is it that they need, as you said? Is it food? Is it transportation? Is it a group of people who they can pour out their heart? What is it? Is it a specialty care? Is it a surgery? Even if it's an unmet need, we fight to make it happen. We believe in underserved medicine, and as all you all do, rather than charity or poverty medicine. Let's face it, our nation has not matured. We're an immature nation. We're like an adolescent with, oh, I can drive, and then we crash the car. So I really believe that as a nation, we have to mature. And until we mature as a nation and recognize that there's a right to health care for everyone,
Yeah.
programs like Dr. Ritter's and ours and all these programs exist to fill a gap that ought to be filled by a mature nation, but we haven't reached it. So then when we provide underserved care, we're recognizing that there are these vast numbers of people who are underserved or unserved, who might be in fear, who might be losing all their right to exist in America. And our job is create environments where they can receive high quality health care. Is it food? And then to see them, for the students, one of our core philosophies is the patient is the teacher. And all the care, just so you know, with student run free clinics, all the care is directly supervised by licensed health professionals. When we say student run, the students are helping with the management, they're helping with the day-to-day ongoing care, but all of it is directly supervised. And then in the third and fourth year, they might be coaches. We do reflection opportunities. And then
Dr. Beck, you've gone on mute somehow.
I thought I was supposed to be done. Tell me, go like this when you'd like me to stop, because I've
Okay.
and I don't mind stopping at all. I don't mind stopping at all. But at the level of faculty, what we did was we looked at three core areas. One was, what are the skills you need to truly create community-based partnerships where the community is the teacher? Second, what are the skills you need to survive in this work? Which are like, how do you write a grant? How do you get promoted? How do you remain intact? How do you even explain what you're trying to do? And then the third is personal and professional renewal, so that there wouldn't be that we can't be martyrs. So we see a trajectory from even before medical school into medical school, throughout medical school, with free clinics and these kinds of experiences, and reinforcing that doctor they dreamed of being, and then retrieving that person at fourth year and say, you can still have these dreams, you can still find a path. And then you go into residency, which is a very narrow place in the river. So how do you help them remain intact? And then into faculty or clinician roles where you provide opportunities for this work.
Wow. That's such wonderful work you're doing, Dr. Beck, because, capturing them young, so to say, in their journey to becoming a physician is when I think they're still tender enough to understand the bigger picture. Like you said, we are not a mature nation, especially when it comes to healthcare. having lived in different parts of the world, I know for sure we can do so much better. So thank you for doing this important work. Awesome. So moving on to our next panelist, my question is to Dr. Loelka. Dr. Loelka, as a specialist working in advanced cardiac care, what role can physicians with specialized expertise play in expanding access to care beyond their regular clinical practice and setting?
I'd like to thank everybody actually learning a lot and likely a lot of things that we're going to implement on our side here in Houston. I'm also glad to hear Gerald here. I think there's some role actually in all organizations to help with the issues that are there. Cardiac care is interesting, and I'll focus on cardiac care, but it probably applies to all the specialties and disciplines. I think one of the roles, if you talk about how can specialists help, is first of all, we're still internal medicine, we're still general surgery, we're still pediatricians at heart, and we, actually need to be in those community clinics doing that part and that role as well. But also accessibility. I think accessibility and, for clinics to know there are physicians who are willing to see patients free of cost, to try to work with their organizations to try to get them into the therapies or the treatments they need. But when you talk about healthcare inequality, it's even worse, I think, in cardiac care. So one of the things you asked me about it is advanced cardiac care. So I do heart failure transplantation. I do what we call structural heart disease, cardiac intervention, all at high levels. I run a lot of research trials. I also do adult congenital heart disease and take care of a lot of those patients. And so when you start looking at care, it's actually even tiered for people who are on Medicare, for example. Recently, as a part of our large trials, we've approved valves now that we can put through the leg, what we call percutaneous valves. And some of those that have gotten FDA approval from recently, they're not available to even my patients on Medicare here in Houston, Texas. Why is that? Well, it's very interesting. Medicare goes by what's called a diagnosis related code. They say, we're going to pay X amount of money for this procedure. A transcatheter heart valve gets a payment of at most, about $44,000 to $50,000 in Houston. That's the whole procedure for the hospital. The patient care, the patient device, the payment for the staff, etc. Well, the companies have priced the valves at $60,000 and $54,000. So none of the hospitals, actually in most of the countries outside 16 states, can afford to put those valves in our patients, and we have to manage them medically at this point. So even if you're on Medicare and you have the best insurance, the payment in Houston, Texas is not enough, but if you go to Manhattan, the payment's $111,000. In California, it may be $70,000. So even within Medicare, there's healthcare inequality. And it's because the companies know that they can charge more money in certain localities. So my patients who have money travel to New York or to Los Angeles. But somebody in rural Mississippi, the payment's $28,000. They can't get access to care. And so when you talk about us not being a mature country, even patients who've paid into the system, all of us pay equal Medicare tax. We don't have equal access. And so that's the first tier that you see in what I do. Forget transplant. Transplant for, people who are in dire conditions, not possible. You may have an 18-year-old who may have a very productive life ahead of them, but there's no access to transplant if you don't have insured care or a mechanical heart. And it's just because, again, the cost associated with the procedures is so high. Still, there's a lot of gap. Again, different layers. We have in Houston, it's
really a remarkable city. You would think, hey, we're in Texas, but we have the most diverse population in the country. We have everybody from everywhere. One of the places, as Kavita knows, that we serve is in the A-Leaf School District. And so there, the problem ends up being that we have kids who are refugees, basically, whether it's Afghan, whether it's Somalia, wherever it's been in the world, they're in those school districts. Those school districts, again, the parents don't have access to health care. They get Medicaid for 2 years and then they're on their own. And so when you look at how do they get cardiac care, it really comes through the bridges that you all provide. And, for us as specialists, it's really important to have those community connections. And, Dr. Beck, to your point, I'm sad to see that the community clinics stop in fourth year med school, right? When you talk about our training not getting them to where they need to be, that needs to be in residency, that needs to be in fellowship, that just needs to be part of the understanding that if we're training you for these things, that you have an obligation to society, the original reason that you did these things, and not just, it stops at, medical school or, a lot of kids will go, they'll do their mandatory rotations early to get into medical school. But when that goes away, they learn that's not the hoop that you have to jump through. And to your point, that disappears. And I'll end with a brief anecdote of how interesting it is when you can't get access to advanced care. I was called from the emergency room from one of our sister hospitals that they were transferring a patient that we had to put on heart-lung machine. Her oxygen levels were 51, 52%. They couldn't raise it up. So actually the call first went to my cardiac surgeon and he said, hey, this lady's coming in. Can you take care of this? I said, sure. And he said, but there's a weird thing. He goes, the chest x-ray is completely clear. And I said, okay, that's interesting. So she got to the lab. Actually, we got access into her venous system pretty quick. And I put an ultrasound catheter up into her heart. Well, lo and behold, she has a hole in her heart and it's shunting blood right to left because she has something called Epstein's anomaly. Now, this lady's 60 years old. She came in from Vietnam at the age of 17. She sees physicians in the community who have put her on home oxygen, not knowing that she actually had a cardiac problem. So we actually put a closure device in her. Her saturations went to 100% and she went home the next day. But she spent 40 years hypoxic without getting access to important care. So, I think there's a role for, specialists in the system. First of all, they have to remember their roots. Number two is provide accessibility. We have the ability sometimes to talk to our hospitals to allow free care. Again, that's another level of engagement that's really important is with your hospital systems because without insurance, they're providing the care for free. And then a real discussion of how do we fix inequality even from a regional point of view, even if you're insured.
Wow, that's a lot of information to digest. And even if you're buying insurance, you are probably underinsured. So that for me
If
has
you've got
been
Medicare in New York is not the same as Medicare in Houston, Texas, even though you pay the same Medicare taxes. And that's a tragedy because the ends of the spectrum for a valve are 28,000 in payment to 111,000 in payment. And it's only the Northeast and California, and that's it that I get adequate payment.
Thanks, Pranav, for sharing that. Okay, so moving on, in the interest of time, we have Pranjali Dani, who is our Associate Director for Sewa. So, Pranjali, through Doctors for Sewa that you've built, this volunteer-led healthcare initiative across communities, what role can medical volunteerism play in expanding healthcare access and community engagement? So, if you could shed some light on that.
Thank you. First of all, let me thank for this amazing forum and for giving me a chance to share my thoughts and experience learned and gathered while volunteering and leading this Doctors for Seva initiative of Seva International. So, going last, I get to summarize or reinforce on many things that my fellow panelists have already said. So there might be some repetition of my thoughts here, or from my thoughts that has already been said. But let me double click on, or start by double clicking on what Doctors for Seva is. So, like we at Seva, the organization believes in serving humanity, it's serving divinity, and that the whole world is one family. So, what better way than to serve those who are marginalized and struggling to access the existing medical care nationally or internationally? Right to good health, as has been said earlier, is the fundamental right, and every able individual with the right comes the responsibility, and with every able individual has this responsibility, I feel, to help and take everyone along. And I believe that every fellow panelist here strongly believes in that. So, Doctors for Seva similarly symbolizes that empathy and tries to become the bridge and a platform to act as an extension to the traditional medical services and to that commitment of quality healthcare for all. And the three tracks of Doctors for Seva are designed towards local support, international support, and helping and assisting the future healers. Medical professionals from different realms and specialty areas from all across US who are committed to enhance that accessibility through community surveys, various forums, have joined Seva International and the platform of Doctors for Seva to serve with that Seva Bhav, the selfless service, and serve the underserved community to provide that humanitarian healthcare experience, I would say. So while doctors provide the medical help, the much needed medical help, large number of non-medical volunteers are also needed to assist in the execution of these programs. And that is what the heart of the model is, I would say, and everybody I think would agree with me. So that's why I like to, believe and say that programs like these are not gap fillers, but we are sort of bridge builders. We are building bridges across different programs and avenues. And to further double click on what I really mean by bridge, and few numbers were quoted by Gerald and by a few other fellow panelists. So if we take the CDC's report from last year, we have around 27 to 28 million people today who are uninsured or are not well insured, underinsured. And as far as the local initiatives or the free clinic sort of initiatives is concerned, even though as per the NAFC data, we have around 1400 plus free clinics, they are still not enough for the amount of population that is underinsured or uninsured. So that's where the volunteerism bridge acts. From clinic to the community, organizations like ours and the chapters across nation are gearing up and taking the needed steps by doing the need finding analysis, by hosting health fairs, meaning to go where the life lives, whether it's in temples, schools, community centers, religious places, not where necessarily the clinic is, right? One of the classic example, like you mentioned, Kavitaji, was during the after school program, and I can recall during COVID times, for example, where in partnership with FEMA, Seva volunteer doctors went to remote places and served or catered over 1,300 plus beneficiaries. And fast forward now, by hosting health fairs at the places where the community is, whether it's events, schools, shelters. The idea and the hope is to make healthcare more accessible and taking the clinic to the patients. And that is where medical professionals and non-medical professionals and the volunteers come together. And for various different reasons, like mentioned here, communities do still face barriers, whether it's economic barrier, language barrier, insurance barrier, or like Maggie was saying earlier, logistical barrier. So when volunteers and the doctors with Seva Bhav do that selfless service, where no billing desk is attached, right? That is where that trust is built. And most of these clinics are run by the volunteers. More than around 80 to 90% of the workforce of the free clinics or the initiatives like this is run by the volunteers. So that is what I think is the volunteer spirit, which bridges the trust. And then that is what Doctors for Seva brings to the table with the engagements, whether it's a short-term engagement or a long-term engagement. But if the care continuity is missing, the model doesn't work, right? We have to have that care continuity path. You can run and have multiple screening events, but that is just the beginning. And the goal for such model is and should always be the consistency and the care continuity path. Doctors can do the preventive and intervention care, but that is where the non-medical, volunteerism plays a role, where they could do language translation, preventive education, follow-up, and that is what I think combined is called healing beyond the clinic in true sense. And another
Yes.
way, another way is for the future healers, for those who are aspiring to make this as their career. And the program that we run here, like you mentioned earlier during my introduction, we run the program called Evolve for those who are aspiring to become those future healers. And the program stands for exploring the virtue of options towards life by volunteering and educating. EVOLVE, Evolve. It was named with the logic that it should be self-explanatory. So it was built to assist primarily our future healers, our medical graduates who are aspiring to join the US healthcare system. And I believe over the period of last 4 years that we have started this program, we have seen over 300 registrants who are prepping and aiming to get into residency and into the American healthcare system. So with the help of experienced mentors, the hope here is to assist them with the needed guidance for their residency, of course, free of cost, but to inculcate that value of giving back to the community, the empathy that is needed while, getting into this healthcare profession. And like Dr. Beck said, and has been doing at UCSD, it's a students run clinic, but it is mentored by the experienced doctors. So to me,
Sure.
when I hear from everybody, volunteerism in this field is not just charity, but it is the network, it is the infrastructure, it is the bridge between the system currently we have and the health equity, insurance equity that we hope and we want. Thank you.
Oh, wonderful, Pranjali. And I think, to the point, meeting the people where they are, meeting the community where they are, and to realize that we are still a young, not mature system. And
Yes.
all of us can do our bit, no matter what sort of background you have, you can assist. You do not have to be a medical student to be a volunteer in a community charity clinic. There are many jobs that you can pick up that can make the system work better. So I think a call for anybody who's attending or listening to this is that you can still help, because together we can make the system work and bridge those gaps that we see. Wonderful discussions, everyone. So in the interest of time, let's quickly move into our round 2 of questions. Maggie, my first question is again for you. When volunteers are brought into a rural health initiatives, what kind of training or support do they need to make sure they're genuinely strengthening care rather than just adding another layer of, another layer for the system, basically? So what are the important training tools that you use and you would want others to use to make sure that it all works and comes together?
I have written so many notes, y'all, from things that people have said this morning. I mean, I just so many thoughts. But I think I think I'm a huge advocate for community health workers, and promotoras and all of that. And so I'd switch the question a little bit as well, because I think what they know, they can teach us.
Correct.
And during COVID, we did a lot with community health workers in North Carolina. There's a standard curriculum that people, have gone through. I know in West Virginia, they use a chronic kind of disease model added on to sort of that basic curriculum. And there's data out there that talks about how incredibly effective these folks are. And time and time and time again, these are the folks that, okay, you go in to see your provider, whomever, and I think, just like Dr. Loico said, you have to go home with people. You have to understand what the resources are there that people are trying to access. We had one of our, so let me just say this too. We trying to thread all of these things together across regions. That's one thing we're really trying to do in North Carolina. I won't spend a lot of time talking about the healthy opportunity pilots that we've done here with the Medicaid waiver, but I think the important thing is weaving these things together so nobody gets dropped, no wrong door. And so, for instance, one of the things that happened in Eastern North Carolina was there was a woman who was living out in the woods. And she came into one of the free clinics. She had a number of concerns. One of them certainly was behavioral health care and a number of things. But it was that community health worker working with the clinic that, number one, had her trust and gradually had her in more stable housing, so that she could be there and participate on a regular basis. So I think, we really have to lift up our community health workers and people who are like that as part of that medical team, because they have experience and expertise that we just don't have about the community and about the resources. So I think the training is there. There's a lot that happened, and that's Atticus, my little dog. So I want to introduce him. But I do think that the NUCA model from NUKA from Alaska, that is, a program that is run, a community health center that is run by Alaskan natives and culturally addressing so many things. And I think also, when you look at Gerald's points about communities also have training that they do, whether it's through faith-based groups or whatever, community, faith-based nurses and clinics and those kinds of things are extremely powerful. So I think, you have to look at the resources that exist in a community. How do you thread those together from community-based organizations to trusted leaders in the community? And just as Gerald said, it might be, yeah. So I would turn that around a little bit in terms of the training. And there are, like I said, a number of curriculums now across the nation that provide that kind of training for folks. But I think the most important thing is, as well, we know if you look at an integrated care model with behavioral health, that becomes part of a whole person care paradigm, having somebody right there in the clinic at that point makes a huge difference in people's behavioral health care. Just like if you have a community health worker who is immediately part of that care team and respected for the knowledge they have and follows people back into the community and knows, well, the person down the street can do this, the person, this other community organization over here can do that. That's the secret sauce. And so I think, that cannot be emphasized more important than anything.
So true, Maggie. And if you meet that one person, whatever social organization setting you are in, that can answer all your questions, it just reduces the client's stress level, and there's a path forward. So just that whole thing that I am in the right place and this is the right person. I've seen that play out in our work every day.
That's right.
You have that one agency on that community case manager who has it seems like I can only imagine what that client that you picked in from the woods, I mean, that is just tremendous amount of work that went in, and the trust that she must have built.
So another hero in the community, because I love lifting up all the work that all of you do. We try to, with our office, try to thread some of these resources together. But a gentleman, his name is Reverend Richard Joyner. And in the day, you probably saw him on national TV and all that. But he is basically a pastor who has a commitment to healthy food. And in a little town in eastern North Carolina, Canida. And what he did was he started, through his ministry and things, he started building raised beds. He started planting healthy food. That became something then that youth got engaged in. Other rural ministries and things got engaged in. And they now have contracts with Food Lion to provide healthy food. They have contracts with the hospitals to provide healthy food. But most importantly, the kids and the community are engaged in how this happens and the purpose of it. And it connects the healthcare back into the community and really essentially creates an economic base also, which is really important for rural. So, it just is, he is one of my favorite people and just such a committed person that his work permeates all of Eastern North Carolina. And he will say to me, he said, Maggie, food banks are okay, but he said that they're over here. What you have to have is you take the food to the people. It's all right if you have a food, a healthy food closet.
A mobile pantry or something.
Yeah, you have got to get people where they are. And I think that's the lesson for all of us.
Yes. Another theme, food is medicine. So the more closer you are to what you're eating, the better it is. So the community garden concept is so powerful. Like in all the communities we serve, we have 2 community centers that have their own little vegetable garden. And these are elementary kids who are tending to this garden with the help of the teachers that are involved in an apartment complex. And we begged the owners to give us a little wasted piece of land where there was nothing, and we turned it into a community garden. A lot to learn. The more you learn, the more you're making healthier choices of what you're eating. So wonderful. Okay, my next question is to you, Joanne. What are the gaps that still exist between the care a patient receives in community clinic and the broader healthcare systems, and how are those being addressed or can be addressed?
So I have to start by saying I'm almost embarrassed to say how fortunate we are in Arlington County. There's one hospital in Arlington County, Virginia Hospital Center. They provide about $4 million of in-kind services to our clinic. I can get x-rays, labs. They share their electronic medical record with us. Their anesthesiologists donate time for free. Surgeons, it's a very close connection. I think it's probably one of the most ideal setups for a free clinic anywhere. And I always wonder, like, when's it going to end? Because it's almost too good to be true. But we kind of do our part. We accept patients who are recently hospitalized and need a lot of care in a prompt way. So that's the biggest one of the biggest things that has filled the gap for us is we actually have access to all the things that most people who are insured have access to. I think this has sort of been referred to already, but a really close network of safety net providers. Again, Arlington's small, but there's the Arlington Community Foundation, and there's a real network of the food pantry, the shelter, Doorways for Women, which is a shelter for women, and all those stakeholders come together. If someone has the ability to be seen at the free clinic, they've met the requirements, they're given a card that's then recognized with the food bank so that the person doesn't have to go through additional steps to get access to food. And then we have a close relationship with the social workers in the hospital as well. So I think that the coordination of care is huge. And we talked about health navigators, community people. I think I would say that one of the most important ways to ensure that the care that's provided on a volunteer basis is actually maximally used is to overstaff or over-resource the clinic. We have about $1.5 million worth of volunteer hours in our clinic. So rheumatologists, orthopedists, cardiologists. If we don't follow through on their recommendations, it's wasted money. It's wasted volunteer hours. And the doctors want to be the doctors. We have doctors who've been here for 30 years, and they realize that if they come here and spend a few hours, that is going to be life changing. It's not going to fall through the cracks. We also ensure that our patients have access to medications. We help them complete the prescription assistance program paperwork, which can be overwhelming. I don't know if anyone's ever seen it, but so that's important. We get biologic agents for our patients, but that requires a staff to accomplish. And then involvement with the broader medical community. I think the focus on really resourcing the clinic, actually hiring people for grant writing, for volunteer services is really important because it presents a professional and responsible view of the clinic. Outsiders. We had an orthopedic doctor specializing in oncology who had to debulk a patient's osteosarcoma, and he is like world class. After the interaction with our clinic, he now sees patients on site as a general orthopedist. So I think that you really have to spend time and money to make sure the clinic is well run, or no one's going to feel like their time is being utilized properly. And again, our community is very affluent, but that's the way we've tried to address the coordination of care, interaction with hospital and other subspecialists, and then having a network of safety net providers that really provide wraparound care. I think the other thing is a few years ago when the idea of a patient-centered medical home became very popular, we tried to model ourselves on that. And that focuses on wraparound services for patients, knowing that, getting chemotherapy and you're too nauseated to take a bus for an hour and a half, and then we can get donated rides from Uber or whatever, or we pay for it, because it's not like you're just wasting your time if you don't help the patient with those things. So I don't think our model is necessarily applicable to a lot of places, but I think we've made the most of the resources that we have, and recognizing that that volunteer hours are extremely valuable in terms of money and engagement, and we have to follow through on the support for the patient, or it's just going to fall through the cracks.
Thank you, Joan. That's actually true. Yeah, I agree with you 100%. Follow through every single time. What good is that recommendation and that volunteer doctor's time if you're not making sure that the patient is doing that? And the wraparound services piece is very important. You're not just seeing that person in an isolated situation. They might have 5 other rental situation going on, food not there, other sick person at the home. So you are treating that entire ecosystem in which they exist. And that's when the wraparound services actually come into play hugely. So I am there with you 100%. Okay, thank you so much. Gerald, our next question is for you. When we talk about healthcare access, we always focus on doctors, hospital, and insurance. Like we've talked on this today, all this time, right? But how important do you think volunteers and community organizations are? And you have talked about it a little bit. Who might, we are looking at people who you think are highly likely to fall through the cracks. It could be something that you see in the organizations that you have worked with. So your thoughts on that, please.
Yeah, I mean, the question is a terrific question on so many different levels. And so I'll try and be brief, but I'll try and separate it a little bit, right? So when you think about volunteers represent the communities that they come from. So in our example, we try and appeal to volunteers that represent the very communities around the world that we want to do business in. So they understand the communities because they're in part of those communities. They hold jobs in communities at various levels of organizations, white collar, blue collar, doesn't matter. So that's the first part. And they represent a voice so that those that don't want to participate can be heard. I also think that when you think about the community services, you've heard Maggie mention, you've heard Dr. Ritter mention this whole thing of safety nets. And you think about the fact that it allows us to see the whole person. So when I think about a volunteer, and I'll give you an example, there's a volunteer we have on our stroke business, and he's a director for a community-based clinic that only specializes in the LGBTQ plus community that has mental health issues. So in addition to sexual orientation, in addition to that also has mental health issues. And so he's bringing a very narrow but very important perspective on voices that need to be thought about in his community that are also applicable to other communities around the country. And then when I think about the organizations that could potentially stand in the gap, the safety net, if you will, they look at that whole person and say, wow, there's a man or a woman or a family that if you think about that whole person, they may have access to care, but the quality of that care is not good. And what do I mean by that, right? If you've ever been in a neighborhood, so I grew up in New York City. I grew up amongst millions of people, and they said, listen, if you get sick, don't go to this hospital, go to that hospital. That plays out all around the world every day. So access to care is one thing, quality of care is another. And so the community health organizations can help be a bridge to that, as can volunteers. But then you think about the social drivers or the social determinants of health. And so, yes, I may have diabetes, I may have cardiovascular disease, I may have mental health service, I may have all of those things. But when you think about food access, when you think about transportation access, so I have people that have access to care, but they have no means to get there. You know, some of my panelists are from rural communities. If there's no means to get to the doctor, then why have care? And then some will get to the doctor only to be asked that there's a copay. And so they can't afford to pay the copay. And so there are so many different gaps in the services that we talk about. So when I think about the importance of a volunteer or the local community organization, they come into the game understanding that all of those things represent the whole person. And yes, if they got care, beautiful. If they have transportation, beautiful. But if they can't afford the prescriptions, because oftentimes, okay, there's a couple of prescriptions, and so someone has to make a choice. between do I keep my cell phone on or do I get the meds or I only get one of the meds and usually it's the cheapest med as opposed to the med that I need. So there's so many different things when you talk about standing in the gaps. And then the last thing I will say is that it leads to life expectancy. I think one of the panelists talked about one part of Virginia, Arlington, Virginia, and then I think they referenced another part where I'm sure the life expectancy is maybe 10, 15, 20 years different, if not more. In this wonderful country of ours, and then that same thing plays out around the world. So when I think about the importance of a volunteer who can bring the voice, that can bring competency around what that community needs. When I think about the local community organization, I think about their bridges to the whole person. So that when I'm just thinking about what's wrong with me, they're thinking about the things I got to go through in my neighborhood and the things I got to go through from a mental health perspective that make sure I get all the services that I need. That's what I think about when I think about falling through the cracks. And then the last thing I'll say is undocumented, unbanked. All of those are aspects of falling through the cracks. And so the importance of data will always be something that we will need to be thinking about because the unbanked person is still a person that has health issues. The undocumented person is still that person that has health issues. And so how do we make sure that we're seeing people, hearing people, and valuing people in all communities, regardless of their circumstances?
Wow, thank you so much, Gerald. I think our reality of our healthcare or the quality of the healthcare is defined by the zip code that we live in. So if you are in a even for nonprofit organizations, for example, right? If you live where there are good organizations in your near vicinity, you have better chances of having access to everything, not just healthcare, but to food and other social services. But if you are living in a rural community, it's obviously a challenge, right? So your reality is the zip code that you live in. And I think all of us need to make sure that we have access, that our community at large has access, and they are service providers that are reaching those rural communities or those marginalized communities. Thank you so much, Gerald, for your inputs there. Dr. Beck, my next question is for you. Volunteer physicians and other healthcare professionals are an important part of free clinic models. What makes medical volunteerism effective from the perspective of practicing physician?
Happy to answer that. And I just want to say that, for food, one of the beautiful things that our students have made happen is that we provide 2 free bags of healthy food, one short-term and one long-term, at every medical visit. At every medical visit. When people come for their medical visits, they get healthy food.
That's a great idea.
To prepare
wonderful.
things and eat together. So that's been joyful. And then we are in schools and churches. Thanks. Schools and churches and also on the street. So we are where, all of us, I think, are where the patients are. So I just think, similarly to what Dr. Ritter said, in order for medical volunteers, and I mean now licensed, yes, there's an enormous need for the non-licensed physician who does all sorts of awesome things for clinics. But if you want licensed physicians and other health professionals, it has to be well structured, easy, safe, legal, and supported. So physicians are busy, but they often want to give back. And a student might call them and say, "Oh, doctor, we could really use your help. Would you teach me? Would you come to our clinic?" And more often than not, the first question is it legal? Is my medical malpractice covered? Can I be there? So the more you can easily set up those structures, and as Dr. Ritter said, maybe it's one night every 3 months, but you have all the follow-up set up, you have all the structure, so they can come and bring their vascular surgery gifts for that night, and then everything else is supported and provided. So then how do we get that medical malpractice? So there are various ways. One are some places where you're all volunteers, the tort systems, but laws. But for example, at UCSD, we appoint anybody who wants to be a clinician volunteer, we appoint them as voluntary faculty. the minute they become voluntary faculty, they are covered in the clinical teaching role, which is what they're doing because they always have students with them. Or what about, let's say it's a Kaiser, or let's say it's a healthcare system in the community. If they believe in truly serving the community and want to show the community, look how we serve, support volunteerism. Say if you spend a half a day a month volunteering somewhere, we will not only consider giving you some time, but even more so, we will cover your medical malpractice. And we encourage it because we believe in the community and we can't serve every patient. So I really, the follow up we talked about, you want to make the clinician feel whatever they can give, you are going to receive. If they can come twice a year, thank you. If they can do three colonoscopies a year, thank you. That's enormous. So you make that happen. And then clauses in our contracts that you can do volunteerism and things like that. And then and that the care is the same. Also, people talked about true access versus false access. I was really glad that Dr. Johnson talked about true access versus false access. Our responsibility, I think, is to help patients navigate to physicians we know or systems we trust, so that when the homeless person is seen or unhoused person is seen for a cardiology specialty service, we had the experience of a particular physician saying, oh, people don't come, homeless people don't come for their visits, so they wouldn't see the patient. They had canceled the visit because they believed the patient wouldn't come. And the patient ended up at some point dying. Now, it's not one specialty or another. It's how do we create, and then charity systems, more often than not, it's our in-hospital specialists that are able to access the quote charity care. I don't like the term, but it is the charity care in a hospital. So they need to be our partners in order to be able. And then finally, how do we say thank you? How do we really acknowledge with appreciation the role that this person has given to be able to really make a difference?
Thank you so much, Dr. Beck. Thank you. That's all very insightful. I think all the fledgling clinics that we are hoping we'll be able to bring in near future through the Sewa network need to look at these fundamentals about the malpractice insurance and other things that you've talked about. Those are things that stump us sometimes. And maybe we'll get in touch with you to learn better on how to do those things and not get intimidated by it so much.
And not to be afraid. The bottom line, like you said,
Yes.
not to be
Yes, not to be afraid.
that there
Yes.
are strategies and to find others. I also want to say that we did create there were fellowships in community medicine that I'm honored that we created the first year-long fellowship in underserved healthcare, and that it is a field.
Awesome.
We have to acknowledge it as a field. And if you have funded fellowships, whether right after residency or later in one's career, then that also creates a body of clinicians that can help serve this work.
That's amazing. Thank you so much. Okay, going on to Dr. Loilka. How can medical professionals and community organizations collab to provide specialized knowledge, mentorship, or telehealth support to patients in communities with limited access to specialists?
So, again, I want to thank everyone. This has been really eye-opening and a lot of learning. I think, specialists, just like everybody else, I think the majority of people would love to help. Dr. Beck, highlighted some of the obstacles that, what do I do with malpractice? What do I do with that? How do you allay those concerns? How do you protect them? Some of it is advocacy, probably at the state level where you have, Good Samaritan laws, you have other things that go into place that protect those physicians or healthcare workers who are really doing it free of cost without expecting any remuneration. So I think, that certainly has to be in place. I also think for specialists, a lot of us don't know where to go. If we want to volunteer, there's really no central directory that sits out there and says, or even advertises, hey, these are the physicians in the community that want to help. And I imagine a lot of you all have either been part of organizations or you've organically gone through friends, contacts. There's got to be a better way, and I don't know, Gerald, if it's the American Heart Association sets up a website or a way to access, hey, if you need cardiac care for, really for, the underserved and, I'm sure there's a whole host of us who want to do that. But how do we put that out on or give access to them? So I think those are the places where organizations can help. And you wonder if you can really make an electronic repository of, hey, I have this patient, he just lost insurance. And that's a real thing in my world too. Where do I send him? Where do I make sure that he can get care? And, even if I can go volunteer in that community or that clinic, where can I go to continue that care? Because healthcare isn't static. Plenty of people get insurance, plenty of people lose insurance. And unfortunately, we're in the age where more people lose insurance. And so how do I, connect with those? And I think, for me as a specialist, the larger issue is connectivity. We in Houston have worked with the Indian Doctors Association. We've worked some with the American Heart Association of, setting up clinics or how do we get into the community so we have a broader organizational umbrella that helps. But I think one of the things, if I take away from everything that I'm listening here, is I wish there was a central information hub of how do we do this? And I think that's lacking, on a larger scale of all of these things that you've talked about. Hey, the community workers. How do if I'm starting a free clinic, how do I know who the community worker is? How do I know that special person out in the community? How do I know who that specialist is that really wants to help? How do I know that there are transportation issues? How do we get all of that done? And, the collective knowledge, I mean, obviously these forums are awesome, but how do we make it so that these forums are really, that information is in one place that somebody can go and say, hey, I want to access this information. Where do I do this? How do I do this? And how do I get a hold of those people? And so I think, when I look at the organizations here, the people are here, I think the bigger question is connectivity, right? I think there's a will for people to do things. How do I know there are organizations that are donating money for these causes? I mean, Dr. Ritter, you've got an awesome system where, hey, you've got somebody who's giving $4 million of healthcare. How do I find I'm sure that's not the only organization that wants to do that, or the only foundation out there that does that. How do we put them in one place where they can make those connections? And I think when I look at all of this, that is one of the biggest things that I take away. How do we access these resources and how do we know about them?
Perfect. Thank you for
right
that
now,
valid question. Sorry,
I just
go
wanted to
ahead.
mention, right now, the National Association of Free and Charitable Clinics is having their annual meeting in Washington, which is why I'm in the clinic today, is because we're giving a tour. I haven't looked at their website for resources, but it's possible there's some there at Innova Fairfax, which is not the same medical system that I'm in, but they do have a repository. But I think it takes someone to keep it up and make sure it's up to date. Make sure one doctor doesn't get all of the patients who can't afford to pay. But yeah, it is. You're right. If it was easy for the doctors, they would see a patient a day or once a week. It's not hard to work them in, right? So
yeah, it's just knowing about it and where to go and who needs that help and how do we connect all these pieces in this puzzle together to, while we're still growing as a country, to understand this
right.
and, make this work better.
Yep. Thank you so much, both of you. My last question is to you, Pranjali. How important are partnerships with hospitals, health systems, community organization, and volunteers and medical volunteerism?
I guess the answer is in the question itself, Kavitaji. You have mentioned most of the pillars which are needed to solve this puzzle, like Dr. Loelka was talking about earlier, right? There is this big puzzle and the connectivity issues or who to reach out to when. So I would say that partnerships are not just important, but they are everything. Without partnerships, a bridge would be or an initiative would be something which leads to nowhere, which doesn't, take you anywhere. Our real learning at Doctors for Sewa or Sewa at large, for that matter, for all the programs and the projects that we run, they are possible only because of one, of course, the selfless volunteers, but because of the partnerships that we have in place at various different levels in the community. And when it comes back to the initiative like Doctors for Seva and its three tracks, everything revolves, I would say, around the pillars and the wheels of partnerships, whether it's community organizations, which brings the trust and the doorway. I would say we can never go alone, or rather, we should never go alone, whether it's serving locally or internationally for medical missions. Without the support of community organizations, we cannot, be successful, or we cannot thrive. Being supplementary to each other, learning from each other. Like I'm learning so much, like Dr. Lolka was saying, right? This forum has been an eye-opening. So learning from each other, supporting each other is the key to this success. And during our recent, like as recent as just 10 days back, the medical mission to Suriname and Guyana, which I was part of, because of the local collaboration with the government and with the various local nonprofit organizations, that is what that made the mission very insightful and successful. And in the US also, it's the same. Our partner organizations play a vital role in connecting all the dots and to bring all the parties together, whether it's beneficiaries, providers, and the administrators. The other pillar or the wheel of the partnership is our health system, the existing health system for the care continuity. If we screen our patients or the individuals today at the local clinics or at the health fair, but if we have nowhere to send the patient back to for that continuity, there is this huge gap. We have created that harm. So the free clinic model or the health fair model must have that process of warm handoffs where a care continuity is
Yeah.
established. The process is documented where local hospitals and pharmacies and the labs are all part of that bigger picture. Like
Perfect.
Dr. Ritter's Arlington's free clinic she was mentioning about, which is piece of the larger puzzle of the continuity model. Or I bet Maggie's work in rural North Carolina also follows a similar approach where community hub connects to a medical clinic or a medical home. The other pillar or the wheel of the partnership comes from the professional organizations, where quality and specialty, is being brought to the table. Organizations and the partnership with the organizations like API, AKI, ADG that Seva has brings those specialties and the expertise and connect that last mile gap and be that bridge for the care continuity. The fourth and the important pillar is the volunteers, the non-medical, volunteers, which becomes the heart for the execution of such programs. While doctors provide that important medical, but the large number of assistance is provided by the non-medical volunteers, like I was saying earlier, to bring care, whether it's by providing rides, making appointments, making phone calls, doing the translation for them, or connecting them with the initiatives like healthy food pantries and much more. All, of course, within the legally allowed, things in the system. But volunteers play an important role. They become the heart to the execution of this big puzzle, or helping in solving this big puzzle. But the other important factor that I heard is the system, the policies in place that govern the healthcare system today. So I feel that we must also ensure that how we can partner better with the system at the federal level, whether it's through organizations like NAFC or at the state level, county level, city level, and be that influencing organization or be the advocate for the policies supporting to better the system for either preventive care or for intervention care. And to bridge the gap, like Dr. Lulka was saying, right? The central hub of resources. We can find this by
Yes.
connecting all these different dots, by talking to these different stakeholders within the system at the state, federal, county, and the city level. So when we say that Doctors for Sewa provides a platform where we deliver the healthcare services to the underserved while engaging our medical professionals in the meaningful opportunities for the community service, it only works all these pillars come together. The trust, the continuity, the expertise, and the heart. That is what makes this one big bridge a sustainable bridge, a Seva Setu, you can say so. So, built by the partners and the partner ecosystem is the key to the success, I would say.
Thank you so much, Pranjali.
Thank
Guys,
you.
we had such an amazing discussion that I only have the third round is
15.
basically a one-liner from all of you. And
Oh, good
what I'm
luck.
asking you guys, I wanted to ask all of you in one line, if you could summarize, what is one recommendation you would give to strengthen healthcare access and community-based care? Just that from all of you. So if we can go with Maggie, your recommendation from today's discussion.
You know, I never do what I'm supposed to do. I never do what I'm told. That's what everybody always
Go
says.
for
Maggie,
it,
you're always wanting
Maggie.
to
Go
do
for
something
it.
else here. So let me just say this. I kind of wrote 3 themes down. I put some things in the chat. And I tell my team, Raleigh is not rural. Rural is not Raleigh. So we talked about workforce. You have to have people trained in rural to provide support in rural. And they will be closer to staying there. Asset-based. People are tired of hearing people say what they don't have and how sick they are. They want to be talked about from an asset place. And then, you know, I think the third thing here is sustainability. And sustainability for all of us means you have a job, you have access to care, you have access to an education. And those are cornerstones of other ways towards health. And the final thing I'll just say is I am just in awe of all of you. It's been such an amazing opportunity to be here with you today. Thank you.
Thank you, Maggie. Dr. Ritter?
If Maggie did 3, do I have to do it? No, I'm just kidding. I think the biggest take home is coordinating with community partners, hopefully through an organization that is kind of a clearinghouse for that. And we heard about the need for shared information, but I think that you're not alone as a healthcare clinic. You have to be part of the bigger safety net and know what they're seeing and how to reach patients.
Thank you, Joanne. Thank you so much. Gerald?
I'm too grateful to everybody. I learned a lot. I'll just share 2 things that I think are pervasive themes. One, let's remind ourselves to think about the whole person. And then my second thing, and this is an industry request, is to get back to connecting with people as opposed to seeing them in a 15 or 20-minute kind of concept, because we're trying to see as many patients as possible. Let's not try and see as many patients. Let's try and connect with as many people as we can in the communities to address these issues.
That's fantastic. That's everything, Gerald. Dr. Beck?
Thank you for saying that, because people in their lives don't fit into 15-minute slots, and that's
No.
why
Yeah.
That's why we're seeing so much burnout. But I do believe that while we advocate and fight for a mature nation, we have to see one person at a time and do the best we can to care for them, that we model and teach and practice a humanistic approach of self-awareness on the part of the clinician and growing, and then kindness where we address the body, mind, and spirit, and we address fear and nourish sources of strength and advocate for justice in an unjust system, recognizing that everybody has a right to quality. So very quickly, Gandhi taught that we must be the change we need to see in the world. But to do Gandhi, we need to
Yes.
do Marley and Garvey, which is to emancipate ourselves from mental slavery and to free our own minds. And like Rumi taught, not to move the way fear moves us, but like King
Mm-hmm.
taught, to injustice anywhere is a threat to justice everywhere. So if we find injustices and we address this, and like Dolores Huerta said, si se puede. And then Hillel taught, if we are not for ourselves, who will be for me? So no martyrs. But if I'm only for myself, what am I? And what can I do now? If not now, when?
Mm-hmm. Perfect. If not now, when? That's how we should end it. Yes, Dr. Loyalka.
You expect me to follow from that? Oh my
It's
goodness.
hard. Trust me.
This is the
It's
wrong
hard.
place to. I just want to say that, the one takeaway, I really enjoyed this because there are people who are leaders in their community who are talking about the real issues that come in, and just very, very humbled. You think that you've done medicine for a number of years and you understand it all, and it's always very delightful when you learn that, hey, there's a lot more to learn here. And so thank you, everyone. Thank you for your information, your knowledge, your compassion. I always tell my residents, quit calling it my 50th case or 1000th case. That's one human being. It's the most important thing that may happen in their lives or their families' lives. Don't trivialize a patient. And it's just incredible to see that here.
Fantastic. That's amazing. Pranjali, yours?
So going last, I guess I can take all the time that is left from the panel. Kidding. But yeah, it was it was an eye-opening experience in last 2 hours, the amount of knowledge and the insight that was shared by all the panelists here. So one reality we are able to supply. We need stronger and larger ecosystem, much bigger, much faster to support our existing medical care infrastructure and create many more such bridges to connect the two sides of the equation, providers and the beneficiaries nationally and internationally. So one thing is clear, I believe that we are headed in the right direction, but only if we can clone these efforts faster. And I can dare to say that I guess we need to move away from the episodic volunteerism to a more trained, more recognized, more sustainable volunteer larger ecosystem. And to continue this and to follow the thought of Ellen that if not now, then when, I would like to add in my closing remarks that we are hosting our first national conference in next month of September, where all the like-minded people, like our fellow panelists today, service-oriented medical and non-medical professionals, will come together to further brainstorm and continue this discussion on various ways and avenues to strengthen and support this effort. It's our first virtual conference, national conference, on 26th of September. And rather than calling this as a conference or as an event, I would rather call it as a supplementary launch pad for the national volunteer workforce and all the ideas that we have discussed here today. And we've been talking about, continue our effort. So please to join. I would like to extend the invitation to each and every one of you,
Absolutely.
to all of my fellow panelists and everyone who joined the forum today. The conference is going to be on 26th of September to co-build this bridge together. And like we like to say, right, together we serve better. Thank you so
And
much.
I love, Pranjali, that you have a bridge in your backdrop. We will not forget this bridge for sure. Okay,
Building more bridges.
wonderful. Yes, building some more of those. Yes. Thank you so much, all. I mean, I don't know where time went by. We were hoping to take some more questions, but I guess we will go ahead and share those questions with the panelists via email. Thank you so much, Maggie, Joanne, Gerald, Ellen, Pranav, and Pranjali for sharing your experiences so openly and sharing the anecdotes from your lives. So those make every discussion more meaningful. Thank you so much for giving us this opportunity to hear from you. I would also like to thank the policy research and thought leadership team that has done all the research. You probably got emails from them. You were able to communicate with them by email. Thank you to that wonderful team of all women, I must say, who have made this happen. So go women. We are very grateful for you for joining us today. If you have time, please stay back on this same Zoom and come back for our next session, which is about, okay, I have to scroll down because we are skipping this, but team, if you could put the scan for the QR code, that would be awesome. So everybody can take a look at the QR code. This is the Sewa Forum QR code, everyone. You can go to this and you can actually learn more about what happened over these 2 days. We have a follow-up session, which is about reimagining service systems in the age of AI, the future of nonprofit management. So that's coming up in just 30 minutes from now. So again, thank you so much. And we look forward to engaging with all the panelists, all of you. We will be reaching out to you to learn more and take our work at Sewa forward in the space of community care and healthcare. Thank you so much.
Thank you.
Thank you.
Thank you all. Of
Bye.
course. Thanks, everyone.